morning, everyone. We're going to go ahead and get started. Dr. Kendra Konzen is going to do the formal introduction, but I just had to say a few words about Dr. Maria Baimas-George, who I think is a force of nature. And I don't know how she does everything she does. And I've really enjoyed my time with her. I hope she has also enjoyed her time with me in the operating room and taking care of patients. And we've also collaborated more recently on a pancreas cancer book for patients. And I just could not imagine how she had the time to put the work into this one book for pancreatic cancer patients. And then I looked at her CV and I noticed she's done 26 of these or so during her training. And I've just never met somebody so organized and so good at taking care of patients and so great in the operating room. And I know she's going to have a brilliant career ahead of her. Dr. Konzen?
Good morning, everyone. It's an absolute pleasure to be able to introduce Maria. She joined us 2 years ago and is currently our senior fellow on the transplant division. And before she came to us, she had a very kind of illustrious start to her career. She is the daughter of an attorney/artist, which might drive some of her interest in what she's presenting today. But it was really in medical school at Tulane, where she also completed her MPH in global surgery, that she started to develop more of an interest in health literacy and education, and then kind of the artistry and the drawings that she's managed to compile over the years. She went on to residency at Carolinas Medical Center, where she worked very closely with the HPB and transplant group there. But it was during that time that she really found a passion for wanting to explain common and not so common medical problems to kids. And so she wrote a series of books, as Dr. Schulich alluded to, The Strength of My Scars. They're really phenomenal. It covers vaccines, appendicitis, cystic fibrosis, and a whole slew of other topics. How she managed to do this, I don't know. But she not only wrote the books, but she illustrated all of them. So she's really just an amazing artist. And it really brings home what she's trying to convey. And then it was here in her first year of fellowship that she became a successfully published author. So a round of applause for that. But she delved into the transplant world and wrote a series of books for kidney transplantation, liver transplantation, living donor operations, and then deceased donor procurement as well, trying to explain that to potential donor families. She's been able to talk about her books and show them across the nation, and multiple transplant centers across the country are now buying her books and distributing them to patients as an adjunct to helping with the education process about what they're going through. Maria is just an amazing individual. She's a fantastic clinician and absolutely outstanding surgeon. So we're very grateful that she'll be in the field of transplantation for decades to come. But without further ado, I introduce Maria Baimas-George.
Thank you, Dr. Schulich. Thank you, Dr. Konzen. Good morning. So again, Dr. Schulich, Dr. McIntyre, thank you for giving me the privilege of presenting today. I really appreciate it. All right, let's hope I can work the clicker. Arrow down on the keyboard. There's a keyboard? Oh, there is. Oh, that did something. Okay. So surgical training for me has been a meandering both inside and outside of structured boxes. My brain constantly craves color, artistry, and creativity. Mike over here, or this one. Oh. My brain constantly craves color, artistry, and creativity. which is one of the reasons I love surgery, because the intersection of art and surgery is considerable, overlapping in technique, inspiration, and evolution. Surgery erupts with color, creativity, and intrinsic art. What surgeon has not said, heard, or thought, what a beautiful technique, what a graceful approach, will you look at those planes? Art in surgery can be all encompassing. If looked for, it is ubiquitous. For the art of and in surgery exists within the body, within the operating room, and within the profession. So first off, my disclaimers. I'm at best an amateur artist. I never took art lessons. I was never formally trained, and you can see my bed looks like it's on a wall. Compare with my mom's paintings, and that's enough said. So here's the outline for the talk. The majority will focus on the first two items, the art added into surgery and the art of surgery, followed by a brief history of art in surgery and the future of art in surgery. So music. Music in the OR, something most of us enjoy, and can be another expression of personality. Michael Wax, he was a lover of the Grateful Dead, which mirrored his surgical demeanor, slow is smooth and smooth is fast. Tom Bach, it's all about Rush. And like Rush, as a surgeon, he believes mastery isn't taught, it's discovered. So he's not afraid of giving learners autonomy. He knows real growth happens when you're trusted to find your own rhythm. Rashik Chowdhury and Trevor Needham, lovers of Eminem and 50 Cent, quick, decisive, controlled chaos. Me, I've become a smorgasbord where my ideal station would involve Eminem, Taylor Swift, Disney, and Bocelli, and I'm really not sure how to interpret that, so. When speaking with my husband, who is entirely non-medical, he's a geology professor. He was shocked that we listened to music in the OR. He thought it might be distracting and divert our attention from surgery. So does it, or does it in fact do the opposite? In 1972, noise in the OR was described as the third pollution and found to be equivalent to traffic noise coming from a freeway. OR decibel levels exceeded the National Institute of Occupational Safety and Health limits for damaging noise at baseline, and that was without the addition of music. With noise being defined as a health hazard, this source of stress per se can impair concentration and communication. So while the noise of the overall workings in the OR are unavoidable, the addition of music to the OR is a choice. So why do we choose it, and is it detrimental? Whether we realize them or not, there are benefits. Music can have a profound effect on your mental state of mind and effect on your technical aptitude. Numerous studies have actually shown this. They demonstrate that music can lift the spirits of the surgical team and improve provider concentration and team communication. There have been quantitative improvements demonstrated in physiologic stress parameters and enhanced operative performance in cardiothoracic surgeons, particularly when music is self-selected. Other studies have assessed muscle fatigue through activation frequency and found decreased activation in robotic surgery in the presence of music. One randomized controlled trial of plastic surgeons found that upbeat cadence increased quality and efficiency of surgical closures. Music genre has also been studied. Novice surgeons performing proficiency-based laparoscopic curriculum with either the Beatles, AC/DC, or no music were assessed at low, medium, and high volume. So what do you think they found? Beatles music at medium volume, efficiency and accuracy increased compared to no music. This effect was lost though when the volume was turned up. A similar-ish impact was seen with AC/DC. However, when volume was increased, speed increased. So ultimately the best results were seen with loud AC/DC. Yeah. Conversely, a review from about 10 years ago found classical music to be the most appropriate OR music, as it evokes mental vigilance and has a positive effect on memory consolidation while inducing relaxing emotions and facilitating an increase in the depth of anesthesia for patients. I published an editorial on this topic in surgery, which elicited a considerable response on Twitter, diving into these topics. And here are some of the responses and takeaways. There was a range of emotions. So what does the data show? A multi-center cross-sectional study found patients highly favored use of music in the OR, perceiving it to improve concentration due to the belief that it alleviates stress and enhances performance. There's even a study that reports anesthetized patients who undergo surgery with music require less sedation or analgesia intraoperatively. Another randomized controlled trial evaluated salivary amylase activity as a surrogate for sedation and found significantly decreased activity in patients undergoing inguinal hernia repair when music was played. So literature, next part of the talk. Here enter the golden snitches. Surgical literature crosses and transcends traditional and physical divisions to create meaningful connections and multidisciplinary conversations across specialties, countries, and even continents. The published words of our peers are essential to improve upon practice with critical analysis. Whether that literature explores surgical personality types with fictional Harry Potter house divisions, or crosses specialty expertise to push bounds of cure and technical resection. It overarches our practice to promote and advance our craft. So my mentor, Dionysus Verhides, he's an HPB liver surgeon in Charlotte. He encouraged me during my research year to do one study where I was really, really passionate about it. So I did, and I chose Harry Potter. And so we created a survey-based study that sought to merge the fictional world of Harry Potter with the personality types of medical specialties. In Harry Potter, for those who don't know, the Hogwarts school was founded by 4 very different wizards who valued particular ethical traits and moralities. They each created their own exclusive house within the school for students who championed such beliefs. Gryffindor favored courage, fortitude, and chivalry, while Hufflepuff believed in loyalty, hard work, and integrity. Ravenclaw supported those with exceptional wit, intelligence, and reason, whereas Slytherin took pride in ambition, resourcefulness, leadership, and guile. Our study hypothesized that if each specialty attracts particular personalities, the percentage of residents that subsequently self-sort into these 4 unique houses will vary depending on which branch of medicine they practice. And that's what we found. There were significantly fewer Hufflepuffs and more Slytherins in surgical specialties. In review of subspecialties, general surgeons had more Gryffindors, whereas ortho had more Slytherins. Peds had more Hufflepuffs, and family medicine did not have a single self-proclaimed Slytherin. So ultimately, I think the real importance of this involves the publication because it was a battle. It took a considerable time to get this article published because it's not traditional. It's not science-y. It's not, it's not our typical article. There were multiple rejections, multiple reiterations, and lots of external advice where I had to pare down a lot of magical wording in the manuscripts to get to the point of article revisions. However, after acceptance, it rose to become the most downloaded article in the Journal of Surgical Education, as well as their most mentioned or cited article in the social media world ever. While most of the feedback in media was largely positive, there were some negative views as well. And what's all this suggest to me? I think the incorporation of art and literature with medicine can transcend our traditional divisions and create meaningful connections and conversations that may not otherwise exist across subspecialties and even countries. It's a creative, artistic stretch from the traditional that makes most people happy. We need to continue to promote out-of-the-box ways to introduce creativity into medicine and surgery. In a world with stress, fear, life, death, challenges, it can only add light. I'll also share with you some of the results that I took out in an attempt to make the article slightly more sciencey and get it published. So these haven't been shared before. They're kind of silly. We polled our respondents as to which specialties would Hogwarts students practice if they were in medicine, as this could be seen as a reflection on qualities that we believe belong in certain fields. So the results. Harry Potter would be a trauma surgeon, Hermione Granger, a surgical oncologist, followed by a neurosurgeon, Ron Weasley, a general surgeon or a trauma surgeon, and finally Draco Malfoy would be most likely a plastic surgeon, followed by an orthopedic surgeon. And these made some sense to me. And then what about in all medical specialties? So Harry Potter would most likely practice in internal medicine or emergency medicine. Hermione, also an internist or a dermatologist. Ron Weasley, family medicine or pediatrics. And Draco is predicted to be in surgery, either general surgery, plastic surgery, or ortho. Albus Dumbledore was envisioned to be in internal medicine or neurology. These votes again reinforce personality stereotypes that may help or hinder individuals in specific fields. Recently, we added to this literature with another study that's currently pending publication, this time focusing only on surgical specialties. Results from 235 surgeons found that most self-reported as Gryffindor, followed by Ravenclaw, Slytherin, and finally Hufflepuff. The highest percentage of each house were found in the following specialties: vascular surgery, Gryffindor; colorectal surgery, Slytherin; ped surg, Ravenclaw; and ped surg, Hufflepuff. The lowest percentages of each house were found in the following specialties: ped surg, Gryffindor; ped surg, Slytherin; and trauma surgery, Ravenclaw. And there were no self-proclaimed Hufflepuffs in vascular surgery, surgical oncology, or colorectal surgery. A subset analysis of all respondents assessed degree of burnout, career happiness, and difficulty in choosing their specialty. Surgeons who sorted as either Gryffindor or Hufflepuff were happier in their careers and less burnt out when compared with Slytherins and Ravenclaws. So perhaps the value traits in Gryffindor and Hufflepuff, those of determination, courage, and hard work, loyalty, tolerance, are protective factors in our field. Conversely, Ravenclaws cherish wisdom and learning, and Slytherins prize ambition, self-preservation, and are achievement-oriented. The surgical field may be more difficult to navigate for individuals who relish power and hierarchical growth, given it is a slow, tortuous road teeming with necessary groveling and servitude, some days. Similarly, those who cherish learning may not be as consistently fulfilled, given the time constraints and velocity of surgical practice can hamper a genuine neurotic plunge into intellectual queries. Over the last decade or so, studies show a disheartening trend in reduction of quality studies that aligns with decreases in financial and organizational research investments. Further, with the advent of large data sets, results can be easily manipulated to find subtle associations that, while not clinically relevant, can be published, thereby introducing them into public domain. Entering words into the PubMed search bar of truth can relay a wide variety of conflicting conclusions from which your own conclusions can be refuted or promoted. Upon comparison of literature trends over the last decade, there has been a positive shift in case design, yet no significant change in study strength. Database studies allow for easy multituditional collaboration, and large population study with immediate results in a cost-effective manner. Whereas RCTs are expensive, often institution limiting, and packaged up tightly in IRB red tape. While literature can promote individual surgeon success through CV line stacking, unfortunately, not all authors can claim ethically appropriate authorship. An anecdotal aside, this institutional pressure or shove for surgeons to present and publish nationally incites a culture of publishing for the CV, not for the profession, for real clinical queries or for fun. There's increased pressure to choose investigative, high-impact avenues that can sway past into not necessarily logical or hypothesis-driven research. A search for significance rather than clinical impact. And when residency positions, fellowship interviews, competitive grants, and long-sought academic promotions rely upon the energy of Alexander Hamilton to write like you're running out of time, our professional culture will suffer. Should case outcomes or clinical productivity not be valued more highly than one's H-index? Literature has a clear role in surgery, yet we must be insightful into our own limitations as we seek to push the boundaries of the field forward. So now for the visual arts. The visual arts are another facet of the benefit of art within surgery. Patient communication in procedural specialties is uniquely challenging, as not only is the pathophysiology needed to be understood, but additionally the perioperative risks and benefits, steps and anatomy changes, and postoperative care. Beyond simple comprehension of all that, retention is required for true consent, personal satisfaction, and transmission to loved ones. The visual arts are a means to help fulfill these facets and provide real additive value. Multiple studies have demonstrated value behind these approaches. Patients benefit from visual resources being provided as part of the consent discussion, particularly for moderate and complex operations. The theory behind this is a dual coding theory of cognition that describes the human mind as being comprised of two functionally independent systems, where visual and verbal information are processed and stored along different channels. This allows an additive effect when both verbal and visual information are both utilized. An audit of a surgery department in Scotland found that even the relatively crude sketches of surgeons were valued as highly as printed forms of image, which made me think of when one of my residents drew a gallbladder. Prior to a cholecystectomy as a chief, I went to consent my patient. My third-year resident already had, and the patient showed me proudly a drawing he did, and I was horrified. And I couldn't decide if it looked more like a one-eyed man wearing a beret or gallbladder anatomy. But the patient loved it. She was thrilled at how the operation had been explained. So when a surgeon draws out an operation, the pace of explanation is rate controlled by the speed of the illustration. This allows for a gradual buildup of detail in both word and image, making complex information easier to process than sudden presentation in a pre-constructed leaflet. It is also being constructed in real time, allowing for dynamic tailoring to a patient's needs and understandings in response to verbal or emotional cues. It's the same reason Sketchy Micro exploded as a popular memorization tool for medical students. 96% of students who use Sketchy Micro have an improvement in exam scores. 81% have improved retention of microbiology. Visual, memorable stories help people understand and retain more difficult concepts. I still remember parts of Sketchy Micro from 10 years ago, and yet sometimes can't remember something from a chapter I read 2 days ago. These studies build upon anecdotal experience, defending the use of visual aids in our practice, whether it be for us as learners to prepare for cases and learn anatomy and technique, for experts to present difficult cases or develop upon standard technique, and last but certainly not least, for patients, to help patients comprehend and retain complex information. My illustrated children's literature has emerged as one such method. When I was an intern, I noticed gaps in patients' and families' comprehension of a disease process and hospital course, resulting in fear, confusion, and misunderstanding. When parents hear that their child is sick, they often forget everything else we say about what will happen and what this means. To compound that, some doctors are just terrible at explaining things. We never learn how to communicate. We go to medical school for 4 years to learn essentially a new language and then expect understanding and recollection, often immediately subsequent to giving a scary diagnosis. Even with using appropriate language, only 10% of the United States has proficient health literacy, and over 33%, which is 77 million people, have difficulty with common health tasks. Thus, most of our patients are not familiar with how a body works and may not understand how to take care of themselves or their dependents. So my solution was to create illustrated children's books. I performed a randomized control study that found improved understanding, satisfaction, and decreased apprehension with the books, as well as positive ramifications, particularly for those with low health literacy levels and/or language barriers. With the responsibility of perioperative recovery also heavily lying upon patients' shoulders, their understanding is paramount for best outcomes. In hopes of improving such, healthcare systems are expanding patient educational offerings to include more illustrated material and videos to complement oral information. I've recently grown this project to include books for adults, given feedback I was getting from providers and patients. Given I'm a transplant surgeon, I started to do research into transplant first. And transplant is a young field, with huge strides continuing to be made in the technical and medical aspects. Whether that is witnessed through the continued success and growth of living donor programs, expansion of transplant oncology indications, or promising outcomes from normothermic regional and machine perfusion. Unfortunately, we have not seen similar matched progress in education and health literacy. And this sits heavy in light of studies that show the role of health literacy in transplant listing, the probability of approval, and post-transplant outcomes. Trials demonstrate that patients who receive quote unquote readable information addressing apprehension, knowledge gaps, and socioeconomic and/or practical barriers related to transplant improve pre and post-transplant outcomes and also reduce racial and socioeconomic disparities. Now, ensuring sufficient education for this diverse population is far from simple, particularly given the complicated nature of transplant. It's confusing for me, and I'm entrenched in it 24/7. It encompasses a wide range of topics, including pathology and immunology, operations with risks, benefits, and post-transplant medications and lifestyle expectations. Unfortunately, in concert with this immense complexity, the vast majority of transplant organizational materials are scored with poor understandability, written well above the average health literacy level of patients and caregivers. And turns out this research is not singular to transplant, but unsurprisingly seen across many adult pathologies, particularly the more stressful diagnoses that involve multiple specialties like cancer. Health literacy is an independent predictor of all-cause mortality. It is consistently associated with ineffective utilization of healthcare services, increased hospitalization, greater use of emergency care, poor ability to demonstrate appropriate medication use, and much more. Some examples. A systematic review of patient education materials for head and neck cancer found that none of the patient education materials, of which this was out of 1,124 resources, were developed for a 6th grade. None of them were developed for a 6th grade or lower reading level. And further, studies have shown in pancreatic and colon cancer that low health literacy is linked to poorer health-related quality of life and also a lower likelihood of receiving chemotherapy. So more books were made, this time for adults, written for the NIH and AMA recommended 4th to 6th grade education levels, written with experts in our field, including our very own Dr. Schulich, Dr. Vogel, Naida, MPH, Kanzen, and Chowdhury. And here are some sample pages. And prospective evaluation of the new transplant adult books have been promising. We've studied patients undergoing a liver or kidney transplant or a living donor. 86 patients were included. 97% of patients were satisfied with the book's content and the way in which the information was presented. 81% of that felt that the book made them feel less overwhelmed, 75% less afraid of surgery, and 94% that the book allowed them to better navigate their transplant experience. It was highly recommended that the books be used by other patients with a 9.3 out of 10 rating. And useful aspects included illustrations, surgical step explanations, glossary of medical terms, and recovery charts. Beyond sole use for patient-reported outcomes, the field of surgery was built upon the back of visual art. Our modern understanding of anatomy arose from anatomists such as Da Vinci and Vesalius in ancient Rome, who published illustrations to disseminate work on cadavers. With the founding of the first medical schools in medieval Europe, anatomy ascended to a prominent position in medical curricula. Followed by the mid-15th century invention of the printing press, there was a scientific revolution in anatomy. Anatomists began to fervently produce texts illustrated with images based on their dissections. And they collaborated with artists, blurring the lines of art and medicine, incorporating landscape, mythology, and Christianity into scientific depictions to create accurate yet beautiful imagery. Illustration continued as the main way to describe increasingly complex surgeries and/or novel techniques. Can see one, do one, teach one become equivalent to see a drawing, do one, draw one? For the visual arts often transcend spoken language and are a universally accessible way to share knowledge. It might be impossible to find a surgeon who does not recognize the name of Frank Netter. His drawings do more than simply teach approach. They help to relay the innate art that lies within surgery itself. Dr. Graham Rosenberg, a cardiothoracic surgeon at Stanford, alternatively uses his doodling to teach proper surgical technique. A former competitive skier, he used to visualize the ski course in detail prior to a race. Similarly, he brings that practice to surgery, putting mental visualization of parts of cases he's trying to learn or teach into drawings. And he quotes, just as small adjustments can help athletes improve their performances, a focus on surgery ergonomics through drawings can aid surgeons. Essentially, a picture is worth 1,000 words. So now for the art of surgery. Dr. Richard Selzer, a surgeon at Yale turned writer, once wrote, "A surgeon's scalpel is not for pressing. It is for drawing across the skin. It is all grace and line, a fierceness. It grins." Surgery is a craft, not a profession. And as such, few if any surgeons will achieve true technical mastery, similar to any other technical craft. Not everyone is a Michelangelo, a Michael Jordan, a Tom Brady. And while one must learn all standard operative steps and memorize them for nervous oral boards relay, the true goal is not to create homogeneous approach conformity. Instead, memorization fosters mechanization of fundamentals, enabling increased independence and efficiency, and focus on subtle deviations and variant anatomy. And just like any other craft, mastery requires effort and time. But what else beyond deliberate practice can have effects on skill, on technical competency? Are there X factors? Inherent nature may triumph, coupled with steel will. Studies find technical skill to correlate with natural visual, spatial, perceptual, and psychomotor abilities, with low scores reflecting a possible inability to attain career competency. And while deliberate practice escalates skill, it does not offset deficits in natural aptitude. What about other artistic experiences requiring high levels of fine motor skills like music? We know there have been several eminent surgeon musicians: Hermann Boerhaave, Theodor Billyroth, Albert Schweitzer, hopefully I said that right, Claudius Conrad. Playing musical instruments involves similar technical skills and extensive training to achieve and maintain expertise. A high level of fine motor skills, quick reaction time, and attention to detail. Studies cite on average it takes a minimum of 10 years of intense involvement and over 10,000 deliberate hours of practice to achieve mastery in competitive fields like music or surgery. So do musicians have a leg up as a surgeon? A prospective cross-sectional study of 50 novice medical student trainees without prior surgical exposure assessed the benefit of a musical background. Novice residents with musical backgrounds demonstrated improved bilateral and non-dominant hand dexterity, speed, and quality of performance with basic surgical tasks, escalating quality of task compared with non-musicians after controlling for age, handedness, sex, and video game activity. There was improved dominant hand dexterity, laparoscopic peg transfer, and suture quality, with the pianists, violinists, and cellists doing the best. And other studies have supported these results. Others have gone even further to see if a cerebral structural adaptation occurs Is there a difference in brain architecture in those with high-level technical skills? Turns out yes. High levels of fine motor skills actually change our brain architecture. Brains of musicians are compared to non-musicians by MRI. The intracerebral length of the precentral gyrus, which is a gross anatomical correlate of the primary motor cortex, was measured. What they found was that musicians had less interhemispheric asymmetry than controls. Then when assessing does the age you start practicing music matter, they found that it did. Age of commencement of musical training was negatively associated with asymmetry. Along with a lot of other neuroimaging studies, this supports the theory that requirements of skilled performances lead to cerebral adaptations. It is unclear if this is due to learning, practice, or innate ability and capacities, but the brain does adapt to extraordinary challenges and requirements of performance, which lead to functional and structural cerebral changes that ultimately may accommodate the requirements of such crafts. And the earlier one starts practicing a technical craft, the more the brain changes, increasing chronic acclimatization. Should we use this information to help select future residents? Should we encourage more task-specific training to improve precision and responsiveness of non-dominant hands? Perhaps. Now, we all know practice and training are essential in surgery, and there's considerable evidence that we learn by doing, which plays a role in surgical outcomes. But what about the reverse? Forgetting after not doing. Think about our practice training in the frame of how other technical performers achieve excellence. Constant practice and repetition. Would a concert violinist vacation without practicing in the days leading up to an important concert? Would an NFL team not practice specific strategy daily the week before a big game on Sunday? Why do we not follow a similar rehearsal pattern? Data demonstrate that as temporal distance between tasks increases, productivity decreases. Reviewing 188 surgeons who performed over 50,000 CABGs, each additional day away from the OR increased the inpatient mortality rate. And an absence from the OR between 3 to 14 days raised the mortality risk by 11 to 14%. Not operating for more than 15 days led to about a 22% mortality risk. Similar results were seen in a single surgeon series of over 2,000 robotic-assisted prostatectomies, with increased days between cases being significantly associated with worse intraoperative outcomes. Another study shows robotic skill degradation after a 4-week period of inactivity for both attending and resident surgeons, with significant increases in time and errors after 4 weeks. Look at Michael Jordan, the actual GOAT's quotes. If you practice the way you play, there shouldn't be any difference. That's why I practiced so hard. I wanted to be prepared for the game. I practiced hard enough that the games were often easier. No one can turn it on without preparing themselves in practice. I had to practice as hard as I could so anything was possible once the game started. I know some players think they could do what I did if they had the kind of freedom I had, but they don't even have a basic understanding of what it takes to be that consistent. You have to fight off double teams, get to the line, knock down at least 80% of your free throws. You have to study the game, find opportunities. You have to figure out ways to beat virtually every one of your opponents. You have to be aggressive at all times mentally, then pick and choose when to attack physically. You have to be able to adjust constantly. And you have to do all these things with the objective of winning. I listened, I was aware of my success, but I never stopped trying to get better. While surgery has many restrictions that do not exist for recreational athletes, due often to system restraints or disease incidents or duty hours, studies findings and simple comparison to other technical specialties, I think still beg awareness. Because the benefits of repetition, as well as skill depreciation with time away from the OR, likely applies to all of us. Now, beyond technique, the surgical artist must also be a calm, omniscient leader during their performance. Yet artistic performance anxiety is a well-documented, studied phenomenon. As a leading cause of non-musculoskeletal health concerns, 1/3 of orchestral musicians suffer from severe performance anxiety, which increases additively in the face of 1, solo acts, 2, evaluative performances, and 3, public audiences. For surgeons, these 3 factors are essentially faced each and every case. Surgery may be akin to a solo act. While some technical elements and some cases necessitate teamwork and coordination, the majority of a case is the responsibility of the primary surgeon on center stage with all eyes and OR lights upon them as they perform lone acts of dissection, anastomotic suturing, and laparoscopic acrobatics, sometimes even projected on monitors around the room. Performance evaluations are bestowed upon surgeons by mentors, colleagues, students, and patients. Whether these evaluations be formal, handle the tissue more deliberately, alternate hands when laparoscopically tying, cut the suture at precisely the right length, or informal, comprised of disapproving sighs and stifled intraoperative passive commentary. The regularity of colleague referrals or opinion requests act as another sort of informal evaluation, whereas lack thereof may act as negative appraisals. Patient evaluations of incisional beauty, bedside manner, or pathologic results can be charged sometimes with undue culpability. Such culpability that should in fact be bestowed upon disease biology or hypertrophic tissue response. Finally, the public audience or surgeons is merely visible to the entire court of public opinion. Online ratings available for any and all to see. Comments, biases, opinions thrust unapologetically and boldly from afar keyboards, tattooed in internet everlasting ink upon each surgeon's not always so thick skin. Some are very positive, like this patient's review of Dr. Schulich, positively glowing, and then some not so much. I've included a rating of my husband, geology professor, as one of the negative reviews so as not to highlight anyone. His student wrote, "So beautiful, but speaks like an English man, uses unnecessarily large and complicated words to just talk about rocks," and gave him a 3 out of 5 rating. So these reviews are available for everyone to see. So if someone does not like your bedside manner or misinterprets a communication style or simply does not like the way you look, your reputation and part of your salary can be subsequently threatened. We're not being evaluated solely by professional judges or referees, but also by crazy fans and haters. Other technical performers deal with hate too. Taylor Swift said, "I know when not to read an article. Is it going to help my day? Is it important for my life? If the answer is no, then I just don't click." I'm careful about getting sucked into the rabbit hole that is the internet because as a songwriter, I don't have the option of having thick skin. As a writer, you have to be open to everything, and that includes pain, rejection, self-doubt, fear. I deal with that enough on my own. If you look hard enough, you could find somebody on the internet criticizing every single thing about you. But here's the catch. Surgeons deal with something other technical performers do not. The purpose of a surgical performance is not entertainment, but for human life, pain, cure, suffering. A surgical concert is played for the highest risk, fraught with crescendos of unexpected complications. And hateful comments can affect anyone, particularly, I can't speak right now, in times of such vulnerability. And what effect that can have upon ability to perform, upon one's confidence and mental state of mind, that might really matter, especially in this hot era of burnout. Perhaps coaching for surgeons should become the norm for every single surgeon, instead of being a punitive response to aggressive outliers or troublemakers. Interestingly, studies evaluating the implementation and effectiveness of coaching in surgical practice found coaching to be highly rated by participants, with nearly half of participants even making changes to their clinical practice directly associated with the coaching. Yet they reported 3 barriers. These included logistical constraints, sure, but also surgical culture and perceived lack of need. So now let's look back briefly at the history of art in surgery. We believe the first attempts at manifesting the art of surgery were seen in prehistoric cave drawings in France. These drawings depicted bison intestinal evisceration after arrow injuries. This was followed in 5000 BC with carvings depicting circumcisions on Egyptian tombs. Since then, other examples have been spotted throughout history. Some of the more well-known include the neurosurgeon Harvey Cushing and the legendary transplant surgeon Roy Calm. Harvey Cushing drew medical illustrations for medical journals while at Hopkins. and eventually his artwork grew to document his patients and their diseases, record operative performances, and pathologies. Dr. Royal Kahn, so he was a British surgeon and one of the most celebrated pioneers in organ transplantation. He performed the first liver, heart, and lung transplant together and the first multivisceral transplant in the 1990s. He also performed the first kidney transplant and the first liver transplant in Europe in the 1960s and the first intestinal transplant in the UK in 1992. He helped develop cyclosporin, one of the first anti-rejection drugs, started the transplant program at Cambridge University, has been knighted, and given all sorts of honors, including the prestigious Lasker Award, which he shares with Starzl for the development of liver transplantation. Colin gives credit for his foray into art to a well-known Scottish painter, John Bellany, who is one of his liver transplant patients. Colin operated on Bellany in 1988, after which they created a close friendship. And inspired by Bellany, Colin began to create paintings to depict the art of surgical transplantation. He attempted to depict the association between painting and illness, with particular emphasis on the surgeon's role in management of disease. While drawing surgical procedures and experiences can be personally cathartic, it also serves a far more practical purpose, helping surgeons visualize, internalize, and communicate complex anatomy and technical schematics. This visual translation becomes especially powerful in training environments, making a natural segue into the final portion of this talk, the future of art in surgery. As we look forward, a growing body of evidence is beginning to show what many of us have long sensed, that the arts are not peripheral to surgical education, but foundational tools that can deepen understanding, improve performance, and humanize the learning experience. Understanding how the brain responds to artistic engagement is more than academic. It has direct implications for how we teach, learn, and perform in surgery. If exposure to and practice in the arts can measurably enhance cognitive function in regions tied to decision-making, coordination, and creative problem-solving, then integrating art into surgical education isn't just enrichment. It may be essential for developing sharper, more adaptable surgeons. In fact, imaging with MRI and EEG assessing non-artists versus artists showed increases in cognitive functioning with diffuse functional changes in the prefrontal cortex and cerebellum in the artists. And a systematic review evaluating existing literature on visual art as an educational tool in surgery found that 12 articles meet inclusion criteria. These studies revealed an array of diverse artistic educational initiatives for surgical residents. Some of these included a randomized controlled trial assessing technical drawing amongst medical students, which led to significant improvement in spatial visualization and anatomy understanding. Pre- and post-operative anatomic drawings and sculptures helped residents conceptualize and learn surgical procedures. Pre- and post-didactic sketching or clay molding of anatomy demonstrated improved information retention in studies of OB-GYN residents, particularly for the lower level residents. And formal art training for plastic surgery residents demonstrated improved ability to communicate technical aspects of operations. The review highlighted all the proposed benefits of visual art supplementation in surgical training, which included improved spatial awareness, surgical anatomy knowledge and retention, 3D thinking, hand-eye coordination, ability to communicate with patients, and wellness. So while art has had significant impact into the development of surgery, its incorporation in modern surgery, which seems like it could be very beneficial, is really almost non-existent. Currently, an art and humanities curriculum is only formally established in a few medical schools and residencies. For instance, the University of Limerick in Ireland offers a special studies module on the humanities and medicine for third years. It focuses on a compilation of paintings referencing health and illness. Brown University offers a full semester course on medical illustration since 2017, led by a peds and OB-GYN professor. The description of the course online discussed how not all sketches are created equal, but just as medical students can be taught how to communicate better with patients and colleagues, so too can the rudiments of sketching be acquired, regardless of whether the student has an innate talent. A recent systematic review of art in surgical residency curriculum found 12 articles with didactics including a component of drawing or sculpture, highlighting again the rarity of art-based study in surgical training. Graphic medicine is another concept that has been gaining traction. First coined in 2007, graphic medicine reflects the value of comics as a resource of communicating about medicine and health. There is now an annual graphic medicine conference and a graphic medicine publishing company through Penn State Press. And many doctors are actually turning to graphic medicine to help expand upon patient understanding and improve medical and surgical consent. In many ways, the ideas I've shared here today echo missions here at CU. In the arts and humanities in healthcare program from the Center for Bioethics and Humanities, especially its commitment to using the arts and humanities to humanize healthcare, deepen empathy, and expand how we teach, learn, and care. Some of the incredible things that it features includes a Lunch and Learn series on the collaboration between health humanities and art research, a music and medicine initiative through performances, lectures, and interdisciplinary collaborations. This initiative celebrates music not just as entertainment, but as a tool to foster empathy, improve well-being, and enhance clinical care. And then an annual anthology called The Human Touch, which showcases original poetry, prose, graphic arts, photography, and visual art by any member of the medical campus community. And it's honestly pretty incredible if you have a chance to look through it and hear a couple snippets. So in the end, surgery is more than anatomy and technique. It is a craft, a performance, and a privilege. And within that space between precision and purpose, there is room for art. Whether it's music in the OR, drawings on consent forms, illustrated books for patients, or curricula that honor creativity. These expressions are not distractions. They're amplifiers of connections, understanding, and meaning. I'd like to extend a sincere thank you to everyone who has coached and encouraged me in my own journey within surgery and art. And thank you again, Dr. Schulich, Dr. McIntyre, and Dr. Konzen.
Thank you so much. Thank you so much for a really stimulating presentation. And I'll take the privilege of the floor. I don't have a creative bone in my body. I've never drawn anything, and I don't play an instrument. What do you say to people like me?
I think like creativity is not just based on these black and white kind of capsules that we put it into, that you have to be a musician, you have to be a drawer, you have to be a painter. There's creativity in a lot of other things that we do that you might not necessarily even realize that you do. So even in how you do your dissections or how you think about patients or how you cook, like there's creativity kind of throughout. And I think in being a surgeon, I think all surgeons have to be innately creative to some degree.
Dr. Beach, and he's the chair of the credentials committee, and somebody was asking me one time about doing trauma acute care surgery and why I still did that when I practiced endocrine surgery. And my response to that was, tonight when I'm on call, I'm going to do something I never have done before. And it's building the blocks of what I need to do through all of the basic steps that I've learned in my other practices. Does anybody else have a question or comment? Dr. Kovacs.
So I have a comment, which is that you don't need to be creative to absorb from the creativity of others. And I think that's an important thing. I'm a visual learner, and I enjoyed the visual aspect of this along with that I understood everything, which is rare for me as rare things. So you don't need to have the creativity to be able to absorb some of this
Have you,
and gain from it.
following up on that comment, have you observed like an example in your career that would illustrate something that Dr. Kovacs pointed out?
Oh boy. I mean, I very much agree with what you're saying. I think in all the patients that I've used visual references for, or, you know, booklets or whatever, it seems like that always, at least from my standpoint, improves our communication and deepens their understanding. And, you know, like not everyone's going to be a creative kind of mind, or what is it, left, right, brain thinkers. And so, but it does seem that that is almost universally helpful. And, you know, whether that's something to do with that dual coding theory of cognition, where you have these two different kind of parallel hallways in your brain, And when you hear something and see something, it ends up being additive or what, but it's gonna help. I think, I agree with you. I think it's gonna help everyone regardless of their creative, artistic ability.
So are you using your transplant books? Do you routinely give these to people during transplant evaluations, or if they get listed? And what kind of feedback do you get from patients or like live donor candidates?
Yeah, so we were giving them pretty much at all of our evaluations. And I was not giving them because I think that since I was studying them, it doesn't bode well that I'm giving it. I'm the author. Hey, read this. But all the feedback we got, because we had a lot of, this initial study, I wanted to use to also hopefully create a better version. So there was a lot of open-ended responses in the survey that the patients filled out. And most of the feedback was honestly, like, I was surprised. I, again, used to just make kids' books. These are kind of my first foray into adulthood. And I thought that some adults might feel belittled, especially if they have higher education. And that wasn't, our group of adults that we assessed, which was 86 patients, came across, there was college, there was GED, there was people who had PhDs and above. So a full range of education. And all the responses, I mean, nearly every single one was that this was incredibly helpful. And we loved the drawings, we loved the visual aspects, we loved, XYZ specific parts, which was really encouraging. And again, I think kind of reinforces that we don't always realize that what we're talking about is really complicated, or maybe not even complicated, but hard to retain and then repeat when you get home and want to tell your loved ones. And so having something like that, that's really kind of word for word in plain, simple English, I think is helpful.
Anyone else have a question? Yeah, Dr. Kovacs.
So I've been to Capitol Hill multiple times to advocate for biomedical research. And one of the things about being on Capitol Hill is that they probably have an 8th grade science faculty. But my understanding is that the public, meaning not the folks in this room, might have a 3rd grade science faculty. So how do you explain these things without being demeaning?
I mean, that's hard because that's how I felt. I didn't know if I was going to be demeaning, but I honestly use there's a lot of crossover with the peds books that I do. So in the children's books, I use an analogy to try to drive home the pathophysiology. So an example would be like dialysis. The analogy is that you have an aquarium with a water filter. And if your kidneys aren't working, it's like a water filter not working in an aquarium. And so the fish poop and food is just sitting around making the fish sick. So you need a working water filter. And so that's what dialysis does. It's a water filter while, your kidneys aren't working. And so I'll incorporate some of that into the adult books, but in like kind of more, I don't know, like hidden ways, not as obvious as a child and an aquarium picture, but incorporate some of that language to be like, think of it like X. But it's honestly kind of a guessing game for me to see what would make the most sense and what doesn't feel belittling and what, would help patients. And so I just try to think of it how I'm a very simple-minded person. And so I try to think about it how I would want to hear something. If I knew nothing about it, what would make sense to me? But I think analogies are really helpful. And then again, just like simple drawings. I think a lot of the illustrations or pictures you look up on Google, if you look up a kidney transplant, it has way too much detail. Just have the kidney with the vessels connect to the vessels. Something really straightforward that really just hits home, hey, this is what a kidney transplant is. Or a picture of the kidney in the pelvis and where the pelvis is, just very simply. And so I think, again, we overcomplicate things. And so really just trying to make it simple.